Good evening, everyone. Thank you for joining Zero for our very first virtual town hall. As everyone starts to join us this evening, I wanted to let you know that if you have a question throughout our conversation, you can enter that into the Q&A box and we will get to as many questions as we can this evening. And with that, I will go ahead and let our CEO, Jamie Burse, take control.
Thanks, Shelby. Good to see you tonight, and good to see you. Good to see all of our panelists, and thank you for joining us on Facebook. Good evening to our East Coast participants, and good afternoon to our West Coast attendees. It's wonderful to have hundreds of you from across the country join us for Zero's very first town hall, which is brought to you by Zero the End of Prostate Cancer and Amgen and Novartis. I'm Jamie Burse, President and CEO at Zero the End of Prostate Cancer, and I'll be your host this evening. Welcome to all of you, and thank you for joining us. We're looking forward to a highly interactive evening with great discussion. Today's town hall is being recorded and will be posted on our website at www.zerocancer.org by Thursday. As soon as our town hall concludes, you'll see a link to a survey, and we would love for you to fill it out as a participant and be able to get your feedback so we can do more of these town halls and make them the best that they can be. On Thursday, you'll also receive an email with a link to this recording along with the survey. In addition, this program is also being live streamed on Zero's Facebook page, facebook.com/zerocancer. Hey, Facebook, welcome. Thanks for joining us. As members of the prostate cancer community, we are incredibly grateful that you've come together and join us for our first ever town hall. And I want to give a special thanks to Dr. Elizabeth Heath, Dr. Kelvin Moses, Vivian Avery, and John Vaughn for being our featured panel and sharing their time, expertise, and experience with us during this town hall. Again, I also want to thank today's program sponsors, Amgen and Novartis, for their support tonight. For those of you not already familiar with Zero the End of Prostate Cancer, we're the leading national nonprofit with a mission to end prostate cancer. Zero advances research, improves the lives of men and families, and we inspire action. We're building Generation Zero, the first generation of men free from prostate cancer, through our National Run Walk series, education and patient support programs, and grassroots advocacy efforts. If you're new to Zero, we welcome you to our community. Here's a quick overview of what to expect as we discuss issues and advances affecting the prostate cancer community. After we do some introductions, we'll jump into four main topics: COVID-19 and you, COVID-19's impact on prostate cancer care, research and awareness, overview of prostate cancer treatment, and side effects of treatment. During each topic, I'm going to pose some questions to our panel, and then we'll take some questions from you. We want to make the best of our time together today and as interactive as possible. So we definitely want to hear from each and every one of you if you've got questions. So please, if you've got one, type it into the Q&A box or post it into the chat feature on Facebook, and we'll be sure to get to them. We will do our best to get to each and every question as long as time allows. All right, so let's get started with introductions. I'm psyched to have this event. You all, thanks again for joining us. So let's meet our panelists, and please tell me a bit about yourself when I call on you. Dr. Heath, it's great to see you tonight. Would you tell everybody, give people a little introduction about yourself?
Hi, everyone. And again, welcome to this really just terrific opportunity to have a conversation with friends and experts. And what we're hoping for all of you tonight is to ask your questions. Don't be shy. We look forward to answering them. So I'm a medical oncologist in Detroit, Michigan, and I practice at the Kermanis Cancer Institute, and I primarily see genitourinary cancer patients, and they're mostly made up of prostate cancer patients. At the center, I am the chairman for the genitourinary cancer group, and I'm also the associate center director for translational science. So I have equal opportunity to harass everyone, including the clinicians and the lab people and EPI and community advocates. And in doing so, we're hoping to really try to do what this wonderful organization is doing finally get rid of prostate cancer. So it's an honor to be here tonight, and I really look forward to having a robust and lively conversation with my colleagues.
Thank you. Dr. Heath is also on our medical advisory board at Zero. And thanks again for joining us tonight, Elizabeth. Dr. Moses is also on our medical advisory board and a member of Zero's board of directors, but he's also so much more than that, including a new dad. Kelvin, would you tell everybody about yourself?
Sure. I'm Kelvin Moses. I am an associate professor of urology at Vanderbilt University Medical Center. I serve as the director of the Comprehensive Prostate Cancer Clinic, where we see men with advanced prostate cancer, as well as run several clinical trials in cooperation with our medical oncology and radiation oncology colleagues. I also have the pleasure of serving as the fellowship director of urologic oncology for the department. And I also get the opportunity to serve on the NCCN and AUA guidelines panels for early detection of prostate cancer. Thanks for having me, and looking forward to a great conversation.
Thank you, Dr. Moses. Next, I'm going to throw it to dynamic Zero champion and prostate cancer survivor. And John, would you introduce yourself?
Sure, Jamie. I'm John Buon. I live just off of Cape Cod in Massachusetts, and I'm a 6.5 year, I guess, survivor of prostate cancer. I had a radical prostatectomy in 2014, and I've been advocating and active with Zero since that time, really. More often than not, just for my real motivation is for my two boys. I have two young adult boys, 36 and 33, and you know, they're always on my mind because my father had prostate cancer. He died with it. I don't even think he knew he had it, but he had prostate cancer. I was diagnosed at 55 with prostate cancer, and now my kids, you know, are going to be facing hopefully a cure, not the cancer. So I'm here to support all the efforts that we can do with Zero and the great group of people that are here tonight. So thanks for having me.
Thanks, John. It's terrific to have you. Next up is a complete dynamo, caregiver and Zero champion and advocate, Vivian Avery. Vivian, would you introduce yourself? You're on mute, Vivian. Those are the tricks to this technology age. There we go. Oh, nope, you're back on mute. We'll also answer some questions.
Can you hear me now?
Yes, we got you.
Oh, great. Okay. I'm Vivian Avery, and I was a caregiver. My father had prostate cancer, as well as my father-in-law, and both of them passed away from that. So I took a lot of I took care of them along with other family members, of course, my mother and mother-in-law. So we saw a lot. My father-in-law's was at stage 4 when it was detected, and it was a rapid growing cancer. And it took a lot out of the family because at the time there wasn't a whole lot of information available as far as what to do, what they're going through. Help for caregivers, because the caregivers are getting basically exhausted trying to take care of the patient. I've been involved with Zero. I believe this is the 8th year, and I am fully committed to that. I'm involved with the Kansas City race. I'm also a summit attendee, and whatever I can do to help Zero get the message out to men and their families about prostate cancer, I do. So I'm just happy to be among this wonderful group today. And I look forward to seeing you all at the next summit, and also passing on any little bits of information I may have. So thank you for having me.
Thanks for joining us, Vivian, and thank you for taking your family's loss and making it into a positive to make sure that no other guy has to go through what your family members went through. So thanks for joining us tonight. Last but certainly not least is our newest vice president, Shelby Munir, who's our VP of Patient Programs and Education. Hey, Shelby.
Hi, everyone. So nice to see you. Jamie, I think you just provided my introduction. But as Jamie said, I'm thrilled to be here. I joined the team in early September as the VP of Patient Programs and Education. We're really looking forward to getting to know all of our champions and patient community and experts on our call and beyond. I came to Zero from the melanoma space, where I was also responsible for the patient and education programs in that space. So I'm thrilled to be here with everyone.
Thrilled to have you, Shelby. Thanks. All right, let's jump in and get right down to business and talk about COVID-19 and you. It's something that's been on everybody's mind for months now. So our first few questions are aimed at our physicians on the panel tonight. Dr. Moses, Dr. Heath, how are you both doing during this pandemic, and what is a very strange year? I sort of get up every morning and I think every day's Groundhog Day. If you've ever seen that movie, every day kind of feels the same. How is it being a physician in the prostate cancer space during this pandemic? Either one, ladies first.
Yeah, so maybe I'll go first. I'm sure our experience is similar and yet different because we do have different things that we do. One thing that's clear during this pandemic is cancer doesn't care that COVID is around. And that's what is sort of the number one message I hope we get out tonight. Cancer moves along. It's nice that COVID is there. It doesn't care that it's there. And what's happened is it's disrupted so many of the, just the daily, not just our daily lives, but in how we try to come up with a treatment plan. So unfortunately, when this first hit, it was oh my goodness, what are we going to do? And how are we going to continue to provide care? And as the months have sort of gone on, it's more of, okay, we've adjusted. I think our messaging is out. We've used more telehealth. There's more discussion on the phone or by some other platform like Doximity and Me, and there's so many others. But I still worry a little bit that the message is still not as clear as it could be, which is, please don't stop your cancer care, even though COVID is there. And that many of our clinics and institutions and universities and hospitals have done what we can from day one to ensure that the patient is safe, and that there is ways around it to continue care. So, on a practice level, it's been a bit difficult because there's been a lot of changes with sort of who's essential versus non-essential in the hospital. So all of our resources are down, but you can bet that your primary clinical team is still there waiting and making sure that people are treated properly.
Thanks, Dr. Heath. What would you add, Dr. Moses?
I agree that we had a similar disruption early in the pandemic, and so patients just weren't coming in, and so the numbers dropped off, and a lot of people either delayed treatment or delayed screening. So we're seeing patients coming in now with probably more advanced disease or unscreened disease. Even though we have protocols in place in our clinic to keep people safe, I have a feeling there's still a fair number of patients who aren't coming in. Some are taking advantage of telemedicine. Unfortunately, the numbers now are actually worse than they've ever been during the pandemic, which is unfortunate. And so I think it's going to be a bit of a tough winter no matter what. Both Dr. Heath and I take care of advanced prostate cancer patients, and so we're always concerned that people who have underlying comorbidities, including cancer, are susceptible to COVID, or particularly susceptible to bad outcomes with COVID. So as she said, I would remain fastidious about keeping your appointments, keeping up with treatments, but also keeping yourself safe and confirming with your physician that they have protocols in place to keep you safe. Having seats that are at least 6 feet apart, everybody's wearing a mask, temperature checks, anybody who has symptoms gets sent home. So I think patients and physicians need to remain diligent during what is turning out to be a pretty persistent virus.
Thanks, Dr. Moses. Yeah, you brought up, it seems to be worse now than it has been in months. I believe that we're seeing over 100,000 new cases a day, maybe 5 out of the last 6 days. So Dr. Moses, as the pandemic continues, how has your advice to patients changed, or has it?
I don't think my advice per se has changed. I definitely try to remain in contact with my patients. So where telehealth is available, we've used it. I am based in Nashville, and I have a lot of my patients who are in rural Kentucky, Tennessee, Mississippi, Alabama, and so they don't always have access to internet or Wi-Fi. So I've been encouraging patients to stay in contact, keep their appointments, stay safe. And my patients are smart. I mean, they know that they have an advanced cancer and that they need to protect themselves. So just to circle back to your question, I'm not sure my advice has changed so much as just to tell them to remain vigilant.
Thank you, Dr. Moses. Dr. Heath, what are you seeing as the biggest obstacles for patients during COVID-19?
I think there's a lot of misinformation out there that's being spread, whether it's through social media or just even the news. And there's just so much information overload that you're just not sure what's real and what is not real. And I agree with Dr. Moses, that the key is maintain communication with your provider. By doing that, even if it's the telephone, I have many patients who don't have smartphones or laptops, but even the telephone ensures that there's some continuity of care. You're right, I can't give chemotherapy over the telephone, but as long as they stay engaged, we can work out, ways to address some of their concerns. I'll tell you, the number one complaint we're getting nowadays is their significant other or family member cannot attend during the visit. And that's really been a struggle, knowing how much I value caregiver and caregiver input, as Vivian, I'm sure, knows. It's just pure logistics. There's just not enough room to maintain social distancing in our visitor space. There's definitely not enough room to maintain social distancing in our infusion areas. And we must keep our doctors and nurses and the rest of the staff safe. And it's a fine balance. So I always try during the visit to call the family member or their caregiver on the phone. We've done FaceTime. We've done whatever it is that needs to happen to maintain that communication. In some cases, it's not enough, but in most cases it is. As long as people feel informed, they're at least feel like they know what's going on and they're a bit satisfied with that. But I don't want that to become an excuse as to why a person doesn't come down. So I hope that, from a messaging standpoint, with technology of today, even if it's on my phone because they don't have a phone, we can do this. We can keep that discussion more than just what the patient has to go through. And it can involve the all-important caregiver or whoever is part of their care team. I think the misinformation is also hard to maintain because things change. We have had updates almost all the time, and every time the numbers go up, it's a different update. The policies change. So that kind of flux over the last several months have heightened the stress level, because they'll say, well, I was just there 3 months ago and you did X, Y, and Z, and now you're changing it. And you're like, yes, I know. I don't make up the rules. I just want to make sure you know that. But, I ask for a little bit of forgiveness and a little bit of flexibility, but don't let that fear prevent you from coming in. And if you're just not sure, just call your doctor, or the care team. They'll be more than happy to answer the phone. And I hear this with my colleagues throughout the country. I'm sure Dr. Moses is experiencing the same. We're there. We haven't gone anywhere. And if that means you just talk to us on the phone, that's okay.
Thanks, Dr. Heath. And Dr. Heath, what resources can patients and families who are in need turn to? And what have you utilized and found as helpful resources that patients could be thinking about during COVID?
Yeah, I think, in some sense, there's been a lot to meet the need. Obviously this organization of Zero, especially 0360, there's so many resources on the website for those who are listening who have not been on the Zero website or is a first time, listener on this town hall. I encourage you to visit that. There's so many different aspects of COVID, whether it's treatment or just concerns on how you keep yourself safe, or questions on whether you're immune compromised or what do you do with your loved one. All of that is usually answered. All hospitals now have a COVID policy as well. But I think for prostate specific, I think your website is, phenomenal. I know the American Cancer Society also has a very good website for information. But I think it's more of just sticking to that line of thinking. Like, it's okay, go find out that information. If you're not sure, make a phone call.
Great. What would you add, Dr. Moses, in terms of resources that patients and families can turn to that you're finding useful and helpful to direct them to during a pandemic?
Yeah, I mean, CDC is obviously the sort of standard bearer, and I would sort of stay away from the politicized aspect of it and stick with the information. But Dr. Heath already pointed out American Cancer Society, Zero, Prostate Cancer Coalition, Prostate Health Education Network. Those are, and then, if you're near a cancer center, an NCI designated cancer center, they too will have information regarding their options.
Great. Thanks, Dr. Moses. Let's flip it over to our champions now and ask a couple questions of them. What wasn't shared as part of the introductions is that both Vivian and John are also mentors within a couple of programs that we have. Vivian helps out some of our caregivers, and they reach out to her to seek advice and lean on her for experience, strength, and hope, as does some of our patients reach out to John to get some of his experience, strength, and hope, and advice during their prostate cancer journey. So as I ask you this, if without naming names, if a story comes to mind when thinking about a patient or a caregiver that you've talked to, please, feel free to share that. But what areas of, Vivian, we'll throw this to you. What areas of your life have been most affected by the pandemic so far? Or have you heard any stories from anybody else who's a caregiver or a patient that has really been affected by the pandemic?
Well, I think the seclusion, our state right now is one of the red states, and we've had just huge influx of positive COVID patients. And I think, the seclusion, they're not able to get around anyone other than the patient they're taking care of. And some of the caregivers are, I think everyone is going through some sort of depression, just because of the seclusion and not being able to do what they normally do. But caregivers in particular, if they don't have someone to relieve them or someone to boost them up and help them through, it really drags them down, because not only are they taking care of the patient and trying to keep the patient motivated and keep them from getting lower and lower as far as depression, they don't have anyone to prop them up. So that's what I'm seeing a lot of. People don't have anyone, and then again, the ones that they do have don't know what to do to help them. So it's kind of a vicious circle, and I try to make myself available to them, to just talk them through it and, kind of pump them up a little bit and let them know it's going to be okay. And, just anything I can do to motivate them, tell them maybe little exercises they should do, or, send them something. I send them stuff in the mail, things to read. Suggest different shows to look at on television that instead of just doing the same old thing. Let's do something different. Let's start looking at the Hallmark Christmas programs or, something like that. But that's where I see that most of our people are being affected in that particular area.
Thanks, Vivian. And I have a confession to make to the whole world that my wife has already tapped in to those Hallmark Christmas shows already.
Me too.
Well, the two of you can have a support group together on how to.
You can throw me in there too, Vivian.
Oh, wow.
Okay, see?
We're really open. That's terrific. Thanks for
Every
sharing.
night.
I certainly miss seeing all of you in person. In fact, Shelby and I have never even met in person. It's just this TV back and forth all the time. Let's turn it over to John. How are you holding up during the pandemic, and how is some of the patients that you've talked to over the last, I don't know, 9-10 months now, how have they been holding up during the pandemic?
Well, everybody's doing the best as they possibly can. And I think, kind of piggybacking what Vivian was saying, it's an emotional time. It's so emotional when you're dealing with the news that you're facing this cancer and you're, ranking, getting ready to battle this thing. And all of a sudden COVID comes into play and there's a whole new set of rules. And then the rules change. And then, and then that's emotional on that side too. So, we so often find ourselves talking about, everything from survival rates and all these facts and figures and percentages and whatnot. But really as from a survivor standpoint, it's an emotional journey. It's an emotional thing that you have to deal with. And I was working with one mentee early on in COVID, and he had been scheduled for surgery. He made the decision after a lot of back and forth, and he had, took quite a bit of time to make the decision to have his prostate removed. So they scheduled the surgery with his urologist, and they were ready to go. And then all of a sudden COVID came into play, and they canceled surgeries. And we all remember that when they were canceling elective surgeries and whatnot. And this particular surgery was canceled because they figured they could wait. So all of a sudden now he's in this waiting game. And then, a couple of weeks later, they call up and say, your surgery's on, we're good to go. And so now in 2 weeks, he's going to have this surgery. So you talk about a roller coaster. I mean, leave COVID out of it. It's a roller coaster. And now throw COVID into the mix, that roller coaster becomes a lot more complicated. And so to what Dr. Heath was saying too, now all of a sudden you're having meetings with your doctors and care team, and your spouse isn't there, your caregiver isn't there, your partner isn't there, your other sets of ears, more importantly, aren't there. And I think it's wonderful what Dr. Heath says is get on the phone and FaceTime and whatnot, because that really, I'm sure would be comforting to both parties, the caregiver and the patient. But there's just no doubt that the emotional part of it is just complicated by COVID, no matter what aspect of and it's not just prostate cancer, it's all these people that are dealing with any kind of health crises.
Thanks, John, and for you and Vivian. Has something been easier to adjust to or accept than you anticipated?
Well, I'll jump in on that,
Sure.
just because it's funny how that's been a process for me, and for a lot of people that I've talked to, is that when COVID first came out, and it has been 9 or 10 months now at this point, because we're well into November now, and there was so much confusion about it. There was so much conflicting information and whatnot, and then we all had to jump through hoops to get used to what was referred to as the new normal. Well, nobody's calling that the new normal now. It's becoming just the normal, like, oh, I forgot my mask and I got to go back to my car before going into the grocery store. This is just now normal. So I think it's been a process, over the past almost a year, to go from complete upheaval to acceptance that this is the way life is for the foreseeable future.
True. What would you add, Vivian? Anything been easier to adjust to or accept than anticipated?
Well, I agree with John. And the fact that we're wearing masks it seems normal to me now. I have them everywhere. And, just to make it entertaining. I have all kinds of masks to go with different clothes. So, that helps me to know that I can still go out now. I haven't had lipstick on in months, so you guys get to see lipstick for the first time on me in months. But where we live, we've got some area around us where we can actually go outside. It's not like we're in the city where we're confined to certain spaces. So we've got the yard, we've got the garden, so that keeps us busy because we don't have to just stay inside. So we work in our yard, I grow flowers, and that helps. It helps a whole lot. And I'm just happy that we are able to do that, and it keeps us feeling normal. This is normal now.
It's great. And your lipstick is lovely, Vivian, just in case.
Thank you.
No one has said so. Make sure to tell your husband, John, that I said it before he could.
And knowing Vivian, I'm sure some of those masks are bedazzled.
They are. They absolutely are. I should have had, well, I don't have one right here, but no, I've got some bedazzled ones.
I know you do.
I do.
I'm sure.
Hey, Jamie, can I pop in to say how much I appreciate both John and Vivian highlighting, really the mental health aspects of this. I mean, prostate cancer or any cancer in itself has a lot of mental health aspects that many people just don't want to deal with or don't acknowledge. But then you throw in the COVID piece and everything just kind of gets all jumbled up. And I do agree with you on sort of the depression aspect and sort of like, well, what do you want me to do? Where do you want me to go and exercise? Just practical things that I don't know if anybody has any good answers, but I do know that from a resource standpoint, most organizations have a mental health professional or a team to help them, and they're doing an awful lot of telehealth visits. So again, they're not your primary, physician, or they're not your primary provider, but they can provide that support, whether it's temporary or long-term, but at least to have that discussion. And, I thought I was doing a pretty good job before COVID, but having COVID, as the normal, as John has said, it really has put that sort of little factor right up front almost immediately. It's not the, oh, by the way, at the end, it's the, all right, how do I actually get you to know what to do and talk about these feelings now, and not when everything is in an overwhelmed state and we're behind. So, thank you to John and Vivian to really focus on that, because I think honestly, we as health providers probably could do a better job because we're so busy in getting the treatment plan right that we forget that that part of it is a critical part of the treatment plan.
Thanks, Dr. Heath. Before we move on, Shelby, anything to add or share?
Yeah, thanks, Jamie. Thanks for this great discussion, everyone. We have a lot of questions coming in. Most of them are pertaining to prostate cancer and its relationship to COVID, and thinking about the vaccine and effects on treatment and diagnosis, and how patients are faring if they are diagnosed. So we'll tackle a little bit of those in a second, but I wanted to just highlight something, Vivian, you mentioned, I think even in your introduction, and that was caregiver fatigue. And just to kind of piggyback on Dr. Heath's comment, caregiver fatigue is something that is, it's a thing. It's a real definition, and it's a thing that caregivers go through. And I think as we're all having these interactions, we have Zoom fatigue at work and throughout our day, and we're constantly on a screen. And it's so important to think about what we can do and who we can reach out to help take care of our mental health. So I really love that part of the conversation. So thanks everyone for bringing that up, especially as it pertains to patients and caregivers.
Thanks, Shelby. We look forward to getting to the questions in the next section. So let's move on to COVID-19's impact on prostate cancer care, research and awareness. I'm going to give this back to you, Dr. Heath. How has the pandemic affected clinical trial recruitment?
Yeah, it's a great question, Jamie. When we first, as a nation, sort of shut down in March, trials shut down as well. because that, in a lot of ways, as many of you know, whether you're on Facebook for the first time or, a first-time patient or a seasoned patient, to do a trial takes a lot of resources. So from just a personnel standpoint, and how do you get from point A to point B to actually start a study and get through that, many moving parts. But all of that are usually folks who are not essential to healthcare. And I don't mean that in a derogatory way, it just means that they're not on the front lines taking care of patients. So to keep everyone safe, including the clinical research staff and the research nurses and everyone, we basically shut down all operations for many months. And I would say nationwide that happened, whether it's for prostate cancer, for all cancers. We know that all NCI designated cancer centers went down to really only opening COVID related trials, so that we could sort of contribute to that. Most of us went back up live in the summertime once we figured out how to keep people safe and how to sort of ramp up. But unfortunately, that was a big hit, I think, for most people throughout the US. So as you guys know, clinical trials is how we advance the science, how we advance drug development, how we advance imaging studies. And all of that really took a big hit. So it's hard enough to get trials on a good year. With COVID, those numbers are definitely severely compromised. So if there is a, second message perhaps that I could get out there tonight, having a clinical trial discussion with your doctor, and it could be about anything. Clinical trials are just not drugs. Sometimes they're quality of life surveys. Sometimes they're just getting your opinions. Sometimes it's on devices. Sometimes it's on imaging studies. Whatever it is, ask your physician, hey, am I eligible for a trial? And that helps us sort of keep, our focus to make sure that you are getting the best state-of-the-art care. But not every center in the US is back online yet. So most of the treatment trials, those are typically drug trials, are back up. But the ones that are not, so again, behavioral or mental health type trials or survey trials, are sort of prioritized in a lower manner because we still need to get the drugs through. So from a resource standpoint, it's a challenge. So I worry, and I constantly worry anyways about trials, but I worry particularly this year that we have to come up with a better way to get folks not just re-engaged, but reassured that it's safe to continue on trials, that we're doing everything possible to keep you safe. So one of the questions I always get, Jamie, is, well, okay, I signed up for this thing, but you want me to come down every month. What if the COVID numbers go up? Do I have to come down? I could tell you that you don't have to do anything on a trial. Trial are suggestions with guideposts. And yes, we'd like you to do that. But if it's not safe, we don't want you to come down just so we can get a data point. We want you to stay safe and get the benefit of whatever it is that you're signing up for. So clinical trials took a big hit across the nation, but many of us are still highly committed in making sure that we move forward. There's still trials that are actively accruing, and I'm just hopeful that people give us a chance to listen and learn and figure out what the possibilities are for them.
Thanks, Dr. Heath. I appreciate it. Dr. Moses, what would you say has been impacted in terms of practicing in urology? You practice urology at Vanderbilt and also City Hospital there in Nashville too, correct? How has urology been impacted through the pandemic?
We saw a pretty steep decline in patients early on, and there's been a slow recovery. Operatively, I think we're back to baseline just because if people need surgery, they need to have it done. And we are COVID testing all surgical patients. I would say overall, though, our clinic is not quite as busy as it used to be. Patients are not coming in. And so, as I said before, we are seeing people coming in with later stage disease or has gone untreated for a period of time and they've experienced recurrence. So, and then as Dr. Heath said, it definitely impacted our clinical trials. We did not accrue any patients really for about 4 or 5 months. And that's suboptimal for everybody, for patients and for us. So that, I think that's been the biggest hit. The winter probably is not going to get much better. Unfortunately, I've had patients who have had family members succumb to COVID. And so I think that gets to kind of the mental health burden. You know, you're already fighting a cancer, you're fighting side effects, and now you're dealing with loss of family and friends. And so we have to be very sensitive about that, inquire about it. I think people, part of the cathartic experience is to kind of discuss things, but we do have to be sensitive to what's going on with people in a more global sense.
Thanks, Dr. Moses. I can only imagine on how far it sets back the development of new diagnostic tools and treatments by delaying clinical trials. So with less activity, lack of a better term, less activity or less patients coming in to the hospital or to the office, you're seeing an uptake in telemedicine. Can you tell us about the role that's playing?
So that's been a lifesaver, literally. And again, for the patients who have access, that's been very nice, and they've been able to avoid traveling long distances or coming into clinic, and it's allowed us to keep our waiting room fairly empty. We have people even waiting out in their car, and we call them in when they're ready. So telemedicine has been a good alternative. It's going to be tough for it to stay around for the long term in urology because there's so much that's literally hands-on, including surgery. And I think it'll be tough for people like Dr. Heath, as she said. You can't give chemotherapy over the internet. And so there are some important limitations, notwithstanding reimbursement issues. So physicians are kind of having to deal with how to code and categorize these type of visits. So there's certainly some challenges, but again, for the patients who need it, I think it's been a really valuable tool.
Thanks, Dr. Moses. I'm going to flip it over to our champions in just a second, but real quick, Dr. Heath, telemedicine, here to stay?
I think it's here to stay in a cohort of people. I tell you, one of the things that COVID has definitely emphasized is the real disparity we have in our country. Again, not talking politics, but just plain old healthcare. Detroit was one of the cities that was hard hit and continues to be hard hit. But it also really sort of emphasizes the differences of what's available. So when I say, yeah, that works if you have a smartphone, the number of people I have with flip phones are many. And they also, if they have a laptop, they rely on their family members who are sort of not with them because it's usually their grandkids or somebody that's like, here, let me help you set that up. And they're not in the house either. So, there's a lot of, I think, social determinants that's impacting telemedicine success for really underserved cities. And also, I would imagine rural populations in the US will struggle with the same issues. I can say that this is a real important topic since we're talking about clinical trials because, the underrepresented group, especially for African-American men, which we know that group has a higher morbidity and mortality, the trial accrual there isn't great, period, pre-COVID. Now, we're in the middle of COVID with impact on trials. I worry that a group that's already underrepresented in so many ways will continue to go down if we don't actively fight against that. And certainly we are trying to, but it really needs to be a nationwide effort. I think there's a lot of emphasis to try to improve our approaches to health disparity in general. But as it pertains to clinical trials, I fear that it might get worse before it gets better. So I think it's on all of us as a community to make sure that does not happen, because we do not have the luxury of having that get even worse. The numbers are already dismal. We can't go to zero unless it's to cure them.
An excellent point on being able to have access to iPhone or iPad or smartphone to be able to do the telemedicine connection. That's flip back over to Vivian and John. How have you been able to continue to create awareness about prostate cancer during the pandemic? Vivian, let's go to you first.
Well, I email folks. I do a lot of talking on the phone because, as the Dr. Heath was saying, everybody doesn't have access to a computer or a smartphone, but they have a phone. So I talk to them. I have people that call me. Matter of fact, I had a good friend that 2 weeks ago called, and he had just been diagnosed with prostate cancer. So we've been chit-chatting on the phone, and of course, I referred him to the resources available with Zero and also a support group. But basically, that's about it. Mailing things out, talking on the phone. I'll talk to whoever I can talk to, pass out my cards to whoever. It could be the person that comes by and, works on the fireplace or whatever. I make sure he's got a card about Zero. So, I just try to encourage people to get checked, do whatever they can. Don't just sit there and wait. I know we've got COVID, but, if something's not right, call somebody and get it checked out, and just be aware of your body. But it's really kind of hard now, can't really do any health fairs, but as I said, I can talk on the phone. So as I asked you the other day, Shelby, about some more information to send out, that's where my information goes. If they can't see it online, they have to see it somewhere. So that's what I do.
That's a great point, Vivian. When we were thinking about resources and we're trying to save trees and be cautious with budgets and finances, but ultimately having something in your hand is really great. I mean, you mentioned it earlier when you said you're sometimes just stick something in the mail for a friend or a caregiver or a patient to get them something in person that's not electronic and not having to stare at a screen. So that's a great point.
Mm-hmm.
Now, how about you, John? How have you continued to create awareness about prostate cancer during the pandemic?
Well, what Vivian's talking about is very important. It's the grassroots effort. It's, one-on-one talking to people and letting them know. But, one of our biggest awareness events throughout the nation were completely wiped off the map this year with COVID, and that was our run walks. The run walk it raises money, yes, and but it also raises awareness. I'll never forget the time we were in the Boston race and we were packing up the tents and we were putting everything away, and some guy came by on a bicycle and said, "What was happening here?" And I ended up talking to him. It was a run walk for prostate cancer. I've heard of that. This is a man probably 50 years old. I go, "What's your PSA?" And he says, "What's that?" And so we had this conversation. And although that is one-on-one, again, but the run walks gave us the opportunity to talk about it, and when we're fundraising, you're able to tell your story. There's a lot of ways that you get behind in the run walk. It allows you to, it always gives you an excuse to talk about it. So, what I've done though is, it's November, no shave November. So I haven't shaved in, I guess, 9 days. And so you do that. And like I'm wearing a Zero sweatshirt now, and I wear a Zero, what do you call these? Bracelets, I guess, the rubber rubber bands. And a lot of times that will just, people will ask about it. They'll see it and they say, what is that? And that opens the door. So that's more important now, I think. What Vivian's talking about doing, and wearing a zero hat or a rubber bracelet, or just whenever you can talk about it and it's appropriate, then you do it. I think that's more important now than ever because we've lost the run walks.
Thanks, Sean. Thanks for sharing. Shelby, what are we getting on the questions line?
All right, lots of questions, and we warned our panelists that they might be a little bit peppered in and somewhat random. So here we go. We've had several questions come in regarding ADT and possible immunity from the coronavirus. I think it was a PCF funded study in Italy, perhaps. I don't want to misspeak, but is there any truth to that? Several of our attendees have forewarned that this could be a rumor, but they wanted to pose the question nonetheless. Not everyone at once.
So Dr. Heath probably knows better than I do, but I'll take a stab. So the Italian study suggested that, they saw that men on androgen deprivation had a lower COVID incidence and mortality. And there were some studies that suggested that one of the genes or proteins that's important in prostate cancer called TMPRSS2 may be responsible for the SARS-CoV-2 virus entering the cell. And with downregulation of TMPRSS2 with androgen deprivation, then possibly men who are getting hormone therapy have lower risk. There's been a study done here in Cleveland which called that into question, particularly since androgen deprivation does not affect TMPRSS2 activity in the lungs, and that's where COVID does its damage. So I think it's a little bit of a mixed bag. I don't think there's anyone who can say definitively that if you're on hormone therapy, it protects you from coronavirus, and there certainly would need to be more studies to get at that answer.
I am in complete agreement. I think Dr. Moses explained that really well. For those interested, the Prostate Cancer Foundation has a terrific website as well, pcf.org, that also has lots of information on prostate cancer, but also on this topic. And, to me, what's exciting is whether the Italian data is right or not. I think that having being able to leverage what scientifically in one particular group to see if that could answer something in another sort of disease state is always a welcomed finding. Science is so complicated that we find all sorts of sort of observations and associations that sometimes should go together. And I think, motivated and smart people agree that there's probably no right one answer, but there are a lot of research now looking at that particular gene and what we should do to sort of think about testing it. I know also the question has come up as to not just ADT, but what if you're on the oral, androgen receptor blockers? Would that also do anything? And I think all of that is all premature and not something that I would recommend. Not that any man without prostate cancer would willingly go on ADT for all sorts of reasons, but that it's really too premature to use that as a treatment, for COVID. But I think the fact that lots of research discussions, and that was one of the very well-attended webinar that PCF hosted, just shows global interest in this topic. So I'm sure it's helpful to further the science, but I don't think it could be drilled down to ADT as sort of the prevention. And I could just say in my own patient population, there's enough prostate cancer patients on treatment that have gotten COVID and, fortunately have survived it, but they're not spared.
Thanks, Dr. Heath. Thanks, Dr. Moses. We've had a couple of questions come in about shortages for with Lupron. Have you heard much about this in your practice, and any idea why or what the status could be?
Yeah, Lupron is made in a factory in Japan, in an area that got hit hard with COVID. And so they had to shut down production. And so, yes, there is a shortage. We have switched to a different medication for now. All of the medications in this family essentially act the same way. There's different formulations, but they pretty much have the same mechanism. But yes, there is a Lupron shortage, and it is a direct victim of coronavirus.
And I would say also the shortage is mostly for the 3-month preparation. There are, some for 6-month, and there's a 4-month preparation as well. So if you wanted to switch to that, which some of my patients have gone for a longer preparation, anticipating they don't really want to come back so often. I do want to note that the activity is the same, but the preparation for the nurse giving it is slightly different. So, we've switched to Eligard at the moment. And the preparation for that is different in the sense that you have to take that drug out, and it has to sort of hang out there for 30 minutes before you can actually inject the patient. So how you put it together is very important. So don't get frustrated that you're hanging around in clinic longer. When I was getting Lupron, this wasn't an issue. One is also a buttock injection, and the other one is a stomach injection. So it's not that we're trying to pull a fast one. It's just, as Dr. Moses said, just not available. But, just if you know that the preparation, period is there, we are informing our patients there's a bit of a delay. So try not to get too frustrated. The minute it's done and ready to go, the nurse will inject.
Great, thank you. I have a question. I think probably John might be the best person to tackle this one. We've had a question and also just a comment about a newly diagnosed patient waiting for some scans, and just, I think, kind of looking for some general support and how he can think about possible anxiety, as we might call it, and waiting for those appointments. And then also just how to communicate with your family. And you mentioned you have children, and how maybe some tips for a newly diagnosed patient.
Well, I think probably one of the worst parts of dealing with the whole prostate cancer thing is waiting for conversations and results and answers. And you're feeling totally helpless because there's nothing that you can do to speed it along, and you're just sitting there waiting for the phone to ring, and your anxiety goes up with every passing moment. So, but there are some things you can do, and number one is be kind to yourself. There's so often times that we as men, maybe, we just kind of want to, bulldoze our way through things and just continue on as if nothing is going on, but something's going on, and you have to face that, and you have to realize that, and take a minute and be kind to yourself. So what that sometimes means is that if you want to watch the Hallmark Channel, then watch the Hallmark Channel. I mean, don't be like, oh, I can't say that that's what I want to do. Say, hey, I would rather watch the football game tonight, even though I know, everybody else in the house would want to watch something different. Go ahead and say what you want, and that'll also help your caregivers and your family or whoever is around you. That'll also help them, feel like they're participating and making you feel better. And that's, I don't know, Vivian can speak more to that, but that's probably important for them as well. But it's tough, waiting for the results and scans and test results it's one of the more cruel parts of the disease. It really is. And so take a breath, realize that time is going to come. And in the meantime, really pay attention to doing something that's going to be good for you. Maybe it's exercising, maybe it's watching the Hallmark Channel, whatever it is. Maybe it's picking up your guitar that you haven't played in 20 years. We're seeing a lot of that happening with COVID too, where people are picking up old hobbies or whatnot. But whatever that is to you, be sure to be kind to yourself.
Thanks, John. I love that answer. I need to hear that too. And I'm not even going through a prostate cancer journey. Thanks for that. Should we move on? In 2020, of course, has been dominated by the pandemic, but there has also been some pretty positive news concerning prostate cancer and making some advancements. I think we can all agree to that. And let's shift over and talk about that a little bit. During the pandemic, there have been 2 new treatments for advanced prostate cancer. Really, a whole new method of being able to fight advanced prostate cancer. Dr. Moses, would you talk about that, about the new treatments that have come out this year and what they do, what they mean, in short?
Dr. Heath knows way more than I do.
All right. Well,
No worries. I'll take this one, Dr. Moses. You know, in May, there were 2 medicines in this family of drugs called Parp Inhibitors. Those who have family members who have breast or ovarian cancer that have the breast cancer gene are perhaps familiar with this class of drugs because it's been approved in the past for them. But what's happened in our prostate cancer world is that we've recognized that the breast cancer gene doesn't play very nice in prostate cancer men either. And it's a source where kind of the DNA readout tells you to kind of do whatever you want to do to make the cancer worse. And in May, we were fortunate to have 2 different pills of the same family be approved really back to back. And it adds to the menu items for men with advanced cancer. You know, one is approved for having had an oral androgen receptor inhibitor. And then the other one is having that plus having had chemotherapy. So they're in a little bit 2 different spaces in terms of the way we think about treatment, but these are oral agents. Now, the tricky part with all of this, Jamie, is that you don't really know if this drug is right for you if you don't test to see if you have the breast cancer gene or some other members in the breast cancer gene family not act right. So what we do know from a recent study that was reported, and ESMO is one of the meetings that happen in Europe annually, and this time it was through the webinars platform, is that in prostate cancer in our community, only 13% of men really get tested. And that number, honestly, is way too low. If you are an advanced cancer patient or a high-risk cancer patient, your number one question to your doctor is, do I need some sort of DNA testing to happen so that I know if certain medicines are right for me? And that's really important because there's no other magic way to figure it out. It's not on a scan. It doesn't show up on your pathology report from either a biopsy or surgery, or even a biopsy, you know, of some other lymph node. It doesn't show up if you, check your blood counts or your PSA. It's a very specific test. So there are different ways to get the test, and that can get a little complicated. And again, if you're really worried about coming down, have the conversation on the phone. As Vivian said, sometimes that's even better than, not doing anything. But there's several ways that we can test for that breast cancer gene. One is looking at an inherited panel, which means this might be some knowledge that might affect your other family members. So we don't take, the doctors don't take testing lightly, because when we find out stuff about you, that's one thing. But if we find out stuff about you that might affect your family, whether it's your children, grandchildren, or even your brothers and sisters or other family members, that's a serious finding, and one that we have to really make sure that we know how to counsel you appropriately. Most of us will refer to genetic counseling. So if that hasn't happened and you have metastatic or advanced prostate cancer, you need to ask your doctor whether that should happen. It's an easy step that we often forget because it's one more step and there's so much to talk about at every visit. So be your own champion and find out. If you have cancer that is, again, spread to different areas, you can look either by tissue, which is, I'm going to check either from your primary prostate sample or from a new area that I'm going to take a sample of, like let's say it's in a lymph node that's new or in a bone area, and that can be processed. So I call it DNA blueprinting, but it's really even more complicated. So it's really just a way for us to know whether you can, in fact, be a candidate for this new class of medication. So Jamie, the long-winded answer is yes, it's really wonderful, but we have a bit of an issue about testing, and we need to test, otherwise we don't know if you're a candidate.
Right, very critical to get you on the best treatment pathway going forward. That's going to have the best impact. Now, a question for both you and Dr. Moses. If you could pick out just one thing, what is the most exciting treatment or development that's going on in clinical trials right now? What's the one thing? You can only pick one thing that's on the horizon coming down. I know I'm trying to elongate my question and buy you some time to think it through here, Elizabeth, but what's that one thing on the horizon? And I'll give you even more time. I'll throw it back to Dr. Moses since he threw that last question in your lap. So I'm putting you on the spot, Dr. Moses. What's that one thing that you're most excited about on the horizon in clinical trials?
Well, yeah, so I'll preface it by saying the Parp inhibitor thing is exciting. It is for a specific subset of men, but that's definitely a new thing. Probably the most exciting, more related to imaging. We've been using Axeman PET scans here in the U.S. for a while, and PSMA PET scan is under several clinical trials. It's really sort of the standard of care in Europe, but there are some trials that are attaching therapeutic molecules to the PSMA ligand or the carrier, so that you can get both very specific imaging and targeted delivery of therapy. So I would say that that's probably the most exciting thing I think that's coming on the horizon for men with advanced cancer.
Thanks, Dr. Moses. What about you, Dr. Heath? What do you think?
Yeah, I agree. And I'm going to also add another sort of exciting development. But from the PSMA standpoint, I think Dr. Moses is absolutely right that, we call that area theranostics. So there is an entire group of agents in that field of theranostics where, again, if you can see it on an imaging, we're going to go and get it. So I think the world of drug development in the area of theranostics is definitely increasing in the last 5 years. We see that for other cancer types, not just prostate. So that's how at least from a class of medicines, it's here to stay. So that's in a lot of ways quite exciting. I think the other, it's a little bit of an offshoot of the PSMA is that the PSMAs themselves are very different. So we now have sort of become more adventurous and are considering treatments that are very similar to what we give for liquid tumor patients. So CAR T cells that's been around for leukemia and lymphoma are now going to be much more active in the prostate cancer area. So I would say in 2021, there's probably going to be several trials. We will have a trial up at the end of next year, again, impacted by by COVID, but because we would have been up already. But from a development and excitement standpoint, that's the combination of trying to tackle your immune system and also leverage all the knowledge that on how the prostate cells work and try to put them together. So some of the PSMAs are in that same area of cellular therapy where they're actually attached to another antibody. So not even just the standard way of giving PSMA. So those are all in clinical trials now. And then the CAR T cells that are coming. So that will be something to keep an eye out for next year.
Thanks, Dr. Heath. Vivian, what's been the response from patients and caregivers about the emergence of Parp inhibitors and just really a new way to be able to attack prostate cancer? You've had your fingers on the pulse of our champion community and our advocates. What have you seen and heard?
Optimism. That's probably the only thing I can say is optimism. Because as the doctors explained, I mean, optimism, you know, unless you really see what's going on and see a lot of positive, all you can do is be optimistic and hope that it's something that's going to work for you. So, you know, that's all I can say, just optimism.
Absolutely. Hope is an extremely powerful medicine when dealing with cancer. But
That it
I'm
is.
not a doctor, so I mean, that may not be true. We'll have to got that through Dr. Heath and Dr. Moses, but I think so. What do you think, John?
Well, I think there's a couple of different stages that people go through. The people that I talked to, you know, there's the people that are newly diagnosed and they're facing urgent decisions and processes, and then there's people like myself who are looking at cancer in a way that maybe a little bit more longer term. I'm 6 years post surgery. I'm not undergoing current treatment, but I'm always concerned, and I think rightfully so, that my cancer could come back either in the prostate or in some other part of my body, and that would still be part of the prostate cancer process. And I think for those of us in that category, we have more time to think about things like that. And I think that there's, you know, tremendous excitement about all the developments that are going on. And there's, you know, like when we go to the Prostate Cancer Summit in Washington, D.C., that's hosted by Zero, you know, we get to meet some of the people, you know, leading the charge in some of this, you know, really mind-boggling research. And I'll be honest with you, I mean, you know, I sell real estate for a living. I'm not the smartest guy in the world, but I can tell that the people that are really working on this are some of the smartest people in the world. And so it's very exciting, you know, knowing that there's going to be developments. We've had 2 major developments this year. If we have 2 next year and 2 the following year and 2 the following year, my kids may not have to deal with the things that I had to deal with as a 55-year-old. So, you know, yes, optimism, excitement, but I think it also depends on the person and where they're at in their prostate cancer journey. I hate to, you know, say that word journey because I don't know, it just brings up different connotations, but it is a journey. It is, you know, where people are in different stages going through the process. And so I think it has a lot to do with where people are at in the process.
Thanks, John. Well said. Shelby, what are we getting for questions from the audience?
Thanks, Jamie. I think we've gotten a couple of questions. We've talked a little bit about advances in treatment and research, and I love that. Can one of you, Dr. Moses or Dr. Heath, speak about the TP53 mutation?
Okay, I'm getting the eyeball from Dr. Moses.
Yeah,
So
give that to Dr. Heath.
you know, TP53 is probably the most well-known gene that has been around for a gazillion years. It is probably the root, as I say, the root of all evil, because many, many different cancers are associated with that. Over the years, there's been a lot of attempts to get drugs to tackle that pathway, but it's around for all these decades because it's a really tricky pathway and it knows exactly how to get around it. Many of the drugs that's been tried has really not made any advancements because it's quite toxic. So, you know, just on your regular cells, it really doesn't play very nice. So we can't really get it off a lot of the early phase studies. You know, in the 25 years I've been doing trials, that is in a way sort of the holy grail of what's happening. Now, I'd like to say that there's been some progress on a different gene, so not BRCA or BRCA, but PTEN. So that has a long name that nobody knows, but that's been around as long as P53 and very, very associated with prostate cancer. But recently, there's been a medication that is an oral pill that was just reported as to be very active, especially in combination with one of the AR drugs. And that gives us a lot of hope because it's, again, a pill that tackles a different gene pathway that we know doesn't work right in prostate cancer. And now there's many, many trials being developed with that strategy in mind. So once one person is always, including myself, forever hopeful for P53, but I don't think that in the next 5 years, we're going to find the magic drug for just that specific one. but P53 loves to play and mess up other genes around it. So as we get better at understanding that knowledge, I think we'll make some headway there. But that's a great question.
Thanks, Dr. Heath. We have another a little unrelated. Why haven't MRIs of the prostate replaced biopsies, and why is the genomic prostate score test not routine?
That's a really good question. Probably the reason that MRI hasn't replaced biopsy is there hasn't been a study that's shown that MRI can replace biopsy. As MRI gets more refined and gets more experienced readers, you certainly are getting better reports. But there's too much data that shows that patients can harbor clinically significant cancer that does not necessarily show up on an MRI. And so people have been reticent to just follow an MRI because of the fear of missing significant cancer. It has been incorporated into a lot of algorithms for following cancer, especially those who are on active surveillance. It's been used for surgical planning. It's used in evidence of biochemical recurrence. But yeah, it hasn't replaced it yet. Probably another reason is just cost. Not every insurance plan will allow everybody to get an MRI. That answer also goes for the genomic testing. Again, not every, there's not quite a zillion, but probably half a gajillion genomic tests out there. They all give different information, and they all come at a cost as well. So again, getting insurance to cover them under the appropriate circumstances. I'm not sure if genomic tests are being underused, but I do think it can give good information, again, for treatment planning for patients who are considering active surveillance, if they're found to be at higher risk and maybe should choose active treatment. So I think it's important to ask your physician if you're on that road, that journey, as John said. You should certainly ask your physician, is there a genomic test that can help give better information? Is there imaging that can help give better information? But neither one of those have perfectly supplanted the techniques that we've been using as a standard.
Thanks, Dr. Moses. Shelby, time for one more?
Yeah, let's do one more. Dr. Moses, you touched on this a bit when you mentioned active surveillance. We got a question from a gentleman who explains that he's of African descent, and when speaking with his provider, mentioned that he would likely never recommend an African American to be on active surveillance. So I would love to hear Dr. Heath and Dr. Moses, your response to that.
Yeah, I would say I never would put a Black man on active surveillance. Early on midway through the sort of active surveillance experience, Johns Hopkins came out with data showing that Black men were more likely to progress, more likely to have slightly more advanced disease at the time of surgery. It was Hopkins, so it's just one center. They have a pretty highly selected population. There have subsequently been other studies, and I would say the data is mixed. We already know that Black men are more likely to be diagnosed with more aggressive disease at a younger age, so those things need to be taken into account. But I have offered active surveillance for Black men, but I am extremely stringent on my inclusion criteria. So they have to have Gleason 6 disease. I have not considered it for Gleason 7 in African American men. They have to have had a confirmatory biopsy. If I can get an MRI, I do get an MRI. And if there's anything that shows up, I advocate for what's called a fusion biopsy, where they can fuse ultrasound and MRI images. I will get genomic testing, and there are a couple of tests that will indicate risk of higher grade disease or higher risk of recurrence. But for the men who meet that inclusion, I will put them on active surveillance. The patient needs to understand that it is a process. And so it is routine PSA testing, is routine repeat biopsies. I do use it with caution, but I do use it.
Yeah, I think that is sort of the strategy that also happens in Detroit. You can't sort of do a one size fits all kind of approach. I mean, at the end of the day, everyone is basically afraid to see somebody like me, because if you see a medical oncologist, all of a sudden you're like, uh-oh, what's that all about? But I have to say that lots of teams now provide the multidisciplinary care, so that whether it's radiation and surgery and med-onc together to kind of address these concerns, that might also help you make a better decision. But I do want to stress that when Dr. Moses says active surveillance, that literally means there's a surveillance and you're supposed to show up when your doctor tells you to, so that that biopsy can be obtained and that rectal exam can be done and the PSA can be obtained. And I say that because a lot of the times you think active surveillance means you take that first biopsy and so on and so on. And then it's like, okay, I guess I'll see you when it's back. So that's not what that means. And I think stressing really what the expectations are is really one way to get the, to get the way that the urologist is intending that approach to be as successful as possible.
Thank you, Dr. Heath. Thank you, Dr. Moses. Let's turn our focus toward side effects of treatment with prostate cancer. Is COVID-19 impacting treatment of side effects? I'm afraid to give it to you, Dr. Moses. You might give it to Dr. Heath, but yeah, I'll throw it at you.
I'll answer it. I don't think so. I mean, we've kind of already touched on, patients not showing up or dealing with telehealth. A lot of dealing with side effects is counseling, specifically for the more advanced patients. So kind of guiding them through what to expect on hormone therapy. We have a cardio oncology clinic. So, patients that have long-term risk for cardiovascular issues, we have them see those patients. And then the other aspects of it are counseling, and that can include psychological counseling as well, because androgen deprivation does put men at risk for depression. So I have several patients who take low dose antidepressants as part of their management, and COVID probably has just exacerbated, any depression. As far as side effects of active treatment, those can be, again, with counseling, with physical therapy, with medication, with surgery. And so if you're in good communication with your physician, they can walk you through that process to deal with those. So I think the short answer of a long answer is that if you're in communication with your physician, whether in person or telehealth, let them know what the side effects are, and then they can give you the appropriate management.
Thanks, Dr.
Moses. I would agree with that. Jamie, I think that, men tend to suck up the side effects more in general. So sometimes you're like, are you sure this didn't happen? How are you feeling with this? So my non-talkers continue to not talk. So they weren't communicating great pre-COVID. They certainly didn't get any better. What we've done to sort of combat that, because what we don't want for folks who are on chemo or immune therapy or any other, more toxic drugs that could create issues, is that we are more proactive as a team. So we'll call and say, usually I tell them to call me, but I sense a reticence because they know the answer. Oh man, if we call Dr. Heath, she's going to make us come downtown. I don't want to do that, so don't call her. So we call, so a week later when I normally don't call, we have our teams call and go, how you doing? And try to get that answer. And honestly, we ask their caregiver, how are they really doing if they're there during the phone call. So I think we're taking a more active approach during COVID because I know the minute that they're in trouble really far behind. That then leads to a more emergent emergency room visit as opposed to come on into infusion and we'll give you some fluids for your dehydration. So that is happening, but I think many practices are changing the way they're approaching it and being more proactive.
Now I know, thank you both. Now I know that one of the side effects that comes up as a result of treatment for prostate cancer is an impact on bone health, whether that's at risk of breaking bones, brittle bones, being able to have good skeletal health as you go through the treatment process. How can that be treated? Has there been any changes during COVID with that, or would you just share a bit about how people who are concerned with that, where can they turn to?
So the NCCN actually has very good guidelines for bone health, particularly for men who are on hormone therapy. Number one, you start out with vitamin D and calcium supplementation, and that's for all men who are on hormone therapy. The other thing we do is get what's called a Dexa scan. That's a bone density scan. It should be performed every other year while you're on hormone therapy. And what it does, it gives you a percent risk of a hip fracture and then just bone fracture in general. And above a certain threshold, then you should consider some of the bone protective agents. Most of them are injections that are given monthly or every 3 months. You do have to have good dental health, or at least have seen a dentist to be on those particular medications, because they can have some pretty devastating side effects. I think one thing that is not emphasized in the guidelines, but I tell my patients, is to do strength training. If you do muscle resistance exercise, that actually causes bone remodeling and can strengthen the cortex of the bones. So really one of the best things that men can do is physical activity with resistance exercises. If you can do a push-up, do push-ups. If you have light free weights, do that when you take a walk. If you have to use resistance bands, anything that can provide muscular resistance actually provides or helps with bone strength.
That is really, I just want to say that's really well said, and I can't underscore the checking of the vitamin D. I think in the state of Michigan, everyone is low, including me. So I know that you have to check. So it comes down to the same issue of, well, I drink enough milk, so it's enough. Nope, you actually got to check the vitamin D level. And that's an easy test that your primary care or your oncologist or your urologist can check. So I think that's something easy that you could do for yourself to make sure that you position yourself to succeed. I think caution also, again, because we live in Detroit, ice and snow will be coming not that far from now. And somehow I still need to say my yearly speech, which is, can you try not to shovel that walk if you can help it? So kind of really making some practical decisions for your own self, so that you put yourself out of harm's way, because a fall is an easy way to really just ruin your quality of life and really get you in trouble. I must say that from an injection standpoint, COVID has resulted in more of, instead of giving monthly injections, to every 3 months. And I think that's acceptable. But I have more requests. I can also say, because COVID has impacted the dentists, and many dentists are not seeing patients, or they're really having, reduced hours, that's also impacted our ability to successfully give bone agents, because as Dr. Moulton said, you really need good dental health to be able to get that. So before maybe things get worse, encourage your patients or your whoever it is that will need these bone agents to go visit the dentist now, so that an assessment can be made.
Thank you both. I know that we're at 8 o'clock now. Let's go for another 10 minutes. It's just a great conversation with great questions coming in. Again, thank you both. Let me flip it over to Vivian and John. John, what from your experience, what side effects of treatment are the toughest to tolerate? Whether it's you personally or some of the mentees that you've mentored, what have you heard or what have you experienced?
Well, I guess the major side effects that, you know, with incontinence and erectile dysfunction and things like that are irrelevant of COVID, you know, so, and a lot of the side effects with the drug therapies that cause side effects like depression or hot flashes and different things like that, you know, those are the same issues whether COVID is going on or not. So I'm not sure that when it comes to a patient, that COVID has had such a direct influence on it, you know, per se. I think that those side effects are the things that you wake up in the middle of the night with, you go to bed with, you wake up in the first thing in the morning. Sometimes you have to think about, no matter what those side effects are. So I really think that COVID has had really no impact, in my opinion, on, and from the people that I've talked to, really has had little or no impact on dealing with the side effects, because let's be honest, the side effects are kind of enough to deal with. Now, logistically, that changes, you know, when your doctor can see you versus in-person and telehealth, which, you know, the telehealth, just to jump back to that for a second from a patient's perspective, I think telehealth is excellent. I think, you know, one of the things that we talked about earlier was the waiting game and how that is so difficult. And if you're waiting for an appointment with your oncologist or with your urologist or with even a primary care physician at this point in time, you know, and you're waiting because you need to get answers and you need to be seen, you know, if you're going to be told you have cancer, I would rather hear it from the doctor on a Zoom call or a Skype or FaceTime than wait another week to find out so that I could see my doctor in person. And that's something I think is, you know, based on, you know, talking to a lot of people, I think a lot of men, especially, at least, will feel that way. So I guess, you know, back to the original question, is COVID, as it relates to the side effects, I think the side effects are just enough to deal with, that COVID just becomes a separate issue, if that makes any sense at all.
Absolutely. Thanks, John. Now, Vivian, how important is it for caregivers and loved ones to understand side effects?
Well, I mean, they're there with their loved one taking care of them, and they need to know what's going on. They need to know if there's anything they can do to help alleviate or help the patient through those side effects. I think Dr. Heath mentioned that some of the men just suck it up and don't say anything, but the caregiver is there all the time. They know that patient. They know their loved one. They know when they're uncomfortable. They know when something's not quite right. So the fact that the caregiver is in tune with them is a positive. And, you know, I just think as long as we've got caregivers that are staying in tune with their patient, their loved one, and, you know, just being very observant while they're going through this, they'll be aware of the side effects. They know, and I think if it gets really bad, they'll make that telephone call to the doctor. They'll do it anyway.
Thanks, Vivian. Shelby, what are we getting on the questions from the audience?
You have a direct side effect question about Xtandi and numbness and tingling, and whether or not it's recommended that patients continue on this, or if there is another option when they're having that side effect.
Well, you know, for Xtandi, numbness and tingling of the hands and feet, which I'm assuming is what they meant, is actually not a side effect from that particular medication. So if you've had chemo perhaps in the past, you might have that as a side effect. You know, we call that numbness and tingling peripheral neuropathy. Now, what can happen also, there's other diseases that can cause that. So diabetes is a frequent one that sometimes you forget that there's other things going on other than cancer that you have to deal with. So many patients who have diabetes that are perhaps not as well controlled for just so many reasons, whether it's just, well, it wasn't well controlled before cancer and now I have to do a double whammy, or because you're on hormone treatment, it makes that diabetes even more difficult to control. If it's something that's been ongoing, that could be why you have numbness of your hands and feet. But the extended toxicities are more in the hormone category. So, things like how the hot flashes and also the blood pressure issues and tiredness and balance issues. So I think I would suggest that they definitely touch base with their doctor to review that side effect, because it's probably maybe there's more things going on.
Thanks. One more, Shelby?
One more, yeah. Any suggestions for just an overall side effect of many treatments, but just dealing with overall fatigue?
I have to say that that's always the number one question that we get, because being on hormone shots and being on any cancer treatment adds to fatigue. COVID adds to fatigue. Being in your home all the time or on Zoom calls add to fatigue. One of the ways that we think helps is exercise. So whether that's a few minutes on the treadmill, a few minutes around the block, if you have a dog, go take it for a walk. If it's even just climbing some stairs in your house. I also say standing is underrated. Sometimes you just need to stand. Now, granted, we've been sitting on, during this call, where it's easy if you're spending the day at home to sit on the couch. Well, stand up. Maybe you don't have a lot of places to go or not a lot of square footage, doesn't matter. You stand up, you use different muscles, do what Dr. Moses was, suggesting, also some stretching and strength training. We know that exercise can really help mood in general, but also in the prostate cancer world, it's definitely shown to just help so many things. And I can't stress enough how important that is to incorporate in your daily regimen.
Yeah, physical activity. I mean, that's what I tell patients. It boosts endorphins, it gives energy. Make sure men are sleeping. I think, I know that energy deprivation can be associated with insomnia, poor sleep habits. And so I tell men to try not to nap too much during the day so that they get tired at night. A lot of men have sleep apnea without knowing it. And I've had several men who get on a CPAP machine and, all of a sudden life is much better. But physical activity, healthy eating, physical activity do wonders for the body.
Thank you both. I want to circle back around just for a last question here, just sort of a rapid fire answer, since we've been talking about COVID and prostate cancer. What's your take on a vaccine? We're going to see one anytime soon, and any hope or challenges around that?
Well, in an effort to be as depolitical as possible, any vaccine typically takes years to develop, not only to see what type of immunity it provides, but how long of an immunity it provides, short-term and long-term side effects. And we don't have that yet. And we also don't know what the coronavirus is going to do. There's already some indication that there's mutation. So it may end up being like the flu vaccine, which is really a combination of several of the common strains that do originate from China. So not calling it a China flu or anything like that. That's stupid. But the flu goes in sort of a global pattern, and it does start in China and sort of makes its way around the world each year. and there's several strains that are involved. And so I don't think it's known whether the SARS-CoV-2 virus will exhibit the same behavior. So I think it's early in the game. As far as a truly effective, safe vaccine, I think we're a long way away, and that's going to be my political answer.
Thanks, Dr. Moses. What do you got, Dr. Heath? Quick answer.
You know, I agree with Dr. Moses. I think those of us in healthcare are, you know, we're trained to think a certain way, honestly, and just there are certain milestones in the way drugs are developed, whether it's treatment for cancer or some infection or heart disease medicines. They all kind of follow a same pattern. Now, I do know just from not just the news, but just from talking to folks that, you know, the news from Pfizer and there will be many others, I'm sure, that will have press releases to show that there's at least some information coming, always excites me in the sense that I am grateful to those who participated in those trials. I mean, if you really think about it, all those thousands of people took whatever they were afraid of and said, go ahead, sign me up and give me 2 shots of this vaccine and see what happens. And that kind of altruism, I think, gets overlooked because everything has been so political. I think the answer is that there are many, many good men and women out there that are doing the right thing so that we can benefit as a global community to probably have more than one vaccine options. And each one is fraught with all sorts of things. You know, one has 2 doses that you need to have. The how you store it in dry ice or in refrigeration of -80 is an issue. How you deploy this throughout the United States and who gets it first is an issue. So the folks on this call and also as part of Zero know everything is about a process. And, you know, the idea of saying, ooh, we have this new drug, you know, that means there are many, many steps that have to happen, you know, from that statement to reality of you showing up for whatever shot at your local doctor or your local pharmacy. So I think, you know, I always remain enthusiastic because I'm a medical oncologist. I'm always enthusiastic. But I am truly grateful for everybody that has participated in those trials. And that's a global participation. And I think that really can't be underscored. So yay to those folks.
Terrific. Dr. Heath, Dr. Moses, Vivian, John, Shelby, thanks for joining me tonight. And this has been a terrific virtual town hall. I also want to thank our sponsors, Amgen and Novartis, for coming on board and helping us bring you this extremely informative town hall. To conclude our discussion today, I'm just going to briefly highlight a couple of Zero's patient support programs. I know that Shelby has already shared many links to inform you about our programs, but it's especially important during COVID-19 to be able to know about these programs and what we have to offer patients and caregivers. And even if it's just to hear that you're not alone in this fight, we've got your back. We're here to support you. First up, we have 2 upcoming educational events that we're hosting. The registration links to these events will be in a follow-up email, as we discussed before, after this town hall. But on Wednesday, November 18th, from 6:30 to 7:30 Eastern Standard Time, Zero is hosting a webinar that's called Financing the Fight of Your Life, Financial Assistance for Prostate Cancer. That is going to be of huge importance. I've seen some studies and some surveys already, excuse me, during the pandemic that as many as half of cancer patients are delaying treatment or not even bothering to go through treatment because of financial distress around their cancer fight. And then also, if you liked a lot of the topics that we covered here tonight, you're going to love our Zero Prostate Cancer Virtual Summit that's coming up on February 28th to March 4th, 2021. Virtual Summit, we're going to bring in people from just around the country, from great speakers and experts to participants from every corner of the country coming together to get informed about prostate cancer and how to help end it. A couple of other programs that we have. It's important to note that because of increased unemployment and loss of healthcare from COVID-19, 0360 has been a lifeline to patients. And 0360 is Zero's comprehensive patient navigation service that provides individualized case management to help patients and their families be able to connect and discuss financial assistance, navigate insurance issues like appeals, and to find other kinds of support, including free transportation and clinical trials. I know that Shelby had put a link in our discussion panel, and it's also on Facebook as well, and you can find out more information at zerocancer.org. And with COVID-19, many patients and caregivers don't have access to the regular support systems like we talked about tonight. So we know talking to another patient, another caregiver who has walked in similar shoes is incredibly helpful when you're in the middle of this fight. So Zero's peer-to-peer support programs like the Mentor program that John had talked about and the Caregiver Connector program, like Vivian had mentioned, match patients and caregivers with someone who's been on a similar journey to be able to provide ongoing support. And you can find more information on that also in the discussion panel for this town hall. And finally, if you want access to passionate and a supportive community at your fingertips, Zero Connect is our own online private Facebook support group for patients, survivors, and caregivers to come and get some advice and share your experience, strength, and hope about your prostate cancer journey, and just to ask questions. It's a group of more than 2,500 members, and everybody on that is there for you. Every question that gets posed on there has got multiple answers and just tons of interaction. So, please look at searching Zero Connect on your Facebook, and it'll come up, and we'll preview and bring you in. As a reminder, all of these programs and resources are at no cost to any patients or families. So if you or someone you know is struggling during their prostate cancer journey, especially during this pandemic, please share these and let them know that we're here to help. More information is available on our website at zerocancer.org. And again, tonight's town hall has been incredibly informative. I want to thank all of our panelists and thank our sponsors, and thank all of you for joining us tonight. And please be sure that when this concludes, there's a short survey. We ask you to please take it so we can continue to improve how we help patients, caregivers, and their families. Thank you everyone for joining us tonight, and have a great evening.